Welcome, my friends, to the Bob and Brad podcast, produced by Bob and Brad, the two most famous physical therapists on the internet. I am Bob, and I'm exactly one half of the Bob and Brad team. Today is truly an honor to be joined once again by Dr. Abbasi, neurosurgeon. Means he's smart, and we've had him on before to talk about a minimally invasive surgery he does for the lumbar spine. But this one is a minimally invasive surgery for the sacroiliac joint. And you're going to find out that, maybe your back pain is coming from your sacroiliac. We'll discuss all that today, along with what the procedure is, where it's at, how to get it. And it'll be worth your time to watch and listen to the show. Welcome to the show, Dr. Abbasi. Thank you so much again for joining us, and we're going to talk about a new topic today. We're going to jump right in. We're talking about sacroiliac joint dysfunction. Why don't we start with what are someone comes in, you suspect SI pain. What are the common tests that you're going to do?
Now, some of the things I learned, and I teach to many surgeons now, is that include that in your differential diagnosis.
Sure.
Again, chameleon joint. If anybody has, if the prevalence of that was like 0.1%,
right,
we usually don't include that in our differential diagnosis. But the prevalence of 22%, I think it absolutely need to get included in any kind of differential diagnosis of the lower back pain. Now, many times, there are other indications, like we talked about young female runners, wake them up in the night, and when they do activity, it goes stairs up and down, pain goes from side to side and so on. The history is very important.
Yes.
You have to start, many of the specialists, we become like so involved and so concentrating on the pictures, on the on the $1 million machine to give us the answer, whereas patient has the most advanced kind of sensory inside of them. They can give you all those information. You should just talk to your patient and put your hand on the patient and examine them. Many of these patients, they put their finger on sacroiliac joint, but you just have to bother, let them stand up, let them turn around that you can look at the back, and you ask them to put the finger on the back where the pain is. And often, they put the finger on where the pain is, where is the sacroiliac joint. We are doctors. I'm not expecting everybody knows where the sacroiliac joint is, but I'm expecting everybody who has gone through the med school to understand where the sacroiliac joint is. Now, and we have even a name for that. We called it 14 test after Dr. 14, who figured out if they point to the location of the pain and within an inch, always they point to the same place, there's a high likelihood that the sacroiliac joint is the problem. Another thing that I think is important is in some of them, not many of them, but at least half of this patient, the other side of the sacroiliac joint, Bob, is our groin. They say, I have pain in the back. Sometimes they tell you, sometimes if you ask them, they say, oh, yes, sometimes I do have pain in my groin, because the other side of the sacroiliac joint is our groin. And then the activities, like going stairs up and down, all those help you to
makes sense.
Get a good picture of if the pain is in the sacroiliac joint. Then if it hints in that direction, the next action on the surgeon side is to provoke that joint. Bob, I know you're a physical therapist, right?
Yes, and I wanted to ask you about the test that you developed.
Yeah.
I know you don't want to call it your name, the Abbasi test.
No.
You should, but
medicine full of names. I always tend to call, like, I have a device that makes something in the surgery much easier, and people ask me to call it Abbasi, but that doesn't say a new person, a new surgeon, what that is.
Right.
Calling that facet decorticator. Every surgeon hears the name, they know what that
What
device
does? Right.
Decorticate the surface of the facet joint in our spine. Every surgeon just need to hear the name. So I'm more for making teaching and learning easy rather than put my name on devices and tests.
It almost seemed to me that, and maybe I'm wrong because I don't know what your test is for sure, but it seems like someone could almost do it on themselves. I mean, they could.
They could.
I mean, first off, if they can't, you want to describe it, but if they can't even do it, that's part of the test, right?
Yeah.
Itself.
Generally, yes, to a certain point you can do it yourself, but it has to be that it's a passive. They have to be passive. Somebody active.
Sure.
Because guess what? Try to stick a needle in yourself. Then you see how tense you become.
Right.
This is same mechanism. It's one of those tests. It's better somebody else can do it for. It's a provocation test. What I learned over many years, do you know who is the best person to do that test? Physical therapist.
Sure.
They are the best people to do this test because they understand the joint. They know how to perform those tests. And the idea of the sacroiliac provocation test is anything that put pressure on it. Now, the fact is that this joint is in the middle of our body. There are lots of ligament attached to that. Sometimes you cannot provoke enough force to provoke this joint. So for that reason, most of the time you use your pelvis and femur as a fulcrum, like a wrench, like a crowbar, to magnify our force to provoke the joint. But the idea, I'm not going to go through the individual kind of test because
you don't
I can
need
send
to.
you, and I think for the populace, it's really
that's. I would like you to describe yours, though, because that would be helpful.
Now, many times I think many of these tests they use your femur, your pelvis to provoke the test.
Right.
Now, and you remember we talked about that when many of these patients in the middle of the night they wake up.
Yes.
Because when they turn from side to side, it's something as well a trivia. People don't know that, but every 15 to 20 minutes in your sleep, even when you're sleeping, you automatically turn from side to side. That is why you don't wake up in the morning having pressure sores, broken skin, because you automatically do that. Now, these poor people, every time they do that, the pain wakes them up.
And that's not surprising to me because we find instability in the lumbar spine the same thing. They'll wake up with pain.
Yeah, exactly. Now, the test that I developed make it easier because to do those tremendous tests, you have to put the patient on a bed. You have to yank their femur, take their pelvis, and push them back and forth. Sometimes you need a place to start before you do those, because if you do that with everybody, it's going to be tremendously cumbersome. But if you want to do a quick test and then if it's positive, do the proper test, you just ask the person to, and I'm going to back a little to show on my own foot here. You ask them to put one leg over the other one. Sometimes they cannot do that. That's already provoking their pain.
Yes.
And then if you gently start pushing down on the knee down, practically you are distracting and extending the sacroiliac joint. And almost everybody who has a sacroiliac joint at one or the other level described to you this action extremely painful. And I'm just going to call it sacroiliac combined test.
All right.
Because that tells everybody that you're practically putting densling test, vapor test, and distraction test together.
All together.
One easy test without putting the patient on a stretcher or a bed. But then if positive, then you still go and do those provocation tests.
And then you were, I'm sorry, I cut you off, but you were about ready to talk about the next step to diagnose is provoking the joint.
So now once the history fits and the provocation test fit, we just have to make sure that that is where the pain is coming from. And the way I describe it to my patient, I tell them, when you go to the dentist, he numbs up your gum on the right side and start drilling on the right side.
Right.
If he numbs up the right side and start on drilling on the left side, that numbing will have no proper action. It's useless. It only works if the pain is produced on the same side, that if you numb it up, that pain goes away. And guess what? And the sacroiliac joint is a very confined place, and there is a very specific protocol to that, which, by the way, has been nationally standardized. Like, you have to do it in a certain way, from certain angle, in certain part of the joint, with certain amount of medication. So you don't want to numb everything. But if you do it properly, and patient will come back and tell you 75% of their symptoms is gone away, and sometimes we ask them to go and do things that are usually painful. And surprisingly, they can come and tell you, yes, 85% of my pain was gone, 90% of my pain was gone. But you have to tell them, I'm just numbing up the joint. So pain will return. As a matter of fact, sometimes if patients don't understand what the diagnostic test is,
right,
this is not a therapeutic test. This is a diagnostic test. Sometimes they come and tell me that, doctor, it didn't help me at all. After 3 days, pain came back even worse. But then my question is, how was it in that 3 days before the pain come back? Oh yeah, it was great for 3 days. But this is the idea of a diagnostic test.
And now, obviously, I think you talked about too that you got to make sure it's in the joint and not the ligaments.
Yes. No. What we do is generally we want to be sure that they didn't get better just because of placebo effect, or they had a good day, or all of a sudden some other things. But I do that test 3 times, meaning that I inject that joint 3 times. If every time I inject that joint, 75% of the pain goes away for a very short period of time, obviously, then we are sure this is where the pain is generated. We call that pain generator. Then we are sure that the sacroiliac joint is the pain generator.
So
and then the diagnostic is confirmed.
3 separate occasions.
3 separate occasions,
wow.
Preferably 2 weeks apart, but at least waiting until the pain is back. Now, there is a caveat here. This is not an easy joint to inject because bone is on bone, the space is very narrow, and because this joint has no function, nature allows lots of variation. Sometimes in the same patient, right and the left sacroiliac joint look different. For that reason, it's not an easy joint to inject, but we can do it if you're trained properly. You just have to go to somebody who has done it enough and knows how to do that, because it is unlike other joints, it's harder than other joints to inject. But the caveat is, once your needle is there, there's no reason not to put a little steroid there. About 1/4 to 1/3 of my patient, after 3 injections, they come back and say, hey, doctor, I'm actually good. I don't want anything else. I say, great. I helped you with all the surgery. I send them out. And unfortunately, though, after 2-3 years, some of them still come back and the joint caused them problem. But now we know what the problem is. So this injection, even though it's diagnostic, by us adding a little bit of a steroid to that, we can as well combine it, making a therapeutic injection at the same time.
Very good.
The beauty of that, and what patient needs to know, is that it doesn't interfere with the diagnostic part. And the reason for that is local anesthetic, which work for the diagnostic part, works right away within 2 days, it's completely gone. As a matter of fact, when you go to your dentist, Bob, and they numb up your gum how long do you feel the numbness?
Well, usually that day. I mean,
6 hours, 8 hours.
Right.
Yeah, but because your gum is well perfused and it washes it out. Sacroiliac joint is not well perfused, so the local anesthetic realistically can stay 1, 2, 3 days, but nothing more than that.
Do you need assistance as far as video to guide you into the right spot, or do you just do?
We use either a CAT scan, CT, or a fluoroscope. Most of the time, we use a fluoroscope, a live X-ray to practically guide us to be in the right place. And then once we put the local anesthetic and we put the steroid, the effect of the steroid is just the first day or two. Steroids start working 4, 5, 6, or 7 days after the injection. So it doesn't confuse you to do both diagnostic and therapeutic injection.
Makes sense. Okay, again, we'll have his website down below in the comments, as well as to the links for the previous presentations on the lumbar spine. So thanks again, Dr. Abbasi.
Always my pleasure.
Yep. Take care.
Thank you. Bye-bye.